now that all the administrative stuff is out of the way, let's get started. We're going to be talking about enhancing motivation in treatment. And this is for mental health as well as substance abuse, because motivation is, after all, motivation. We want to conceptualize motivation and identify ways to increase it. We want to identify things that often prevent us from increasing motivation, and understand that motivation is about making the most rewarding choice among current options. We don't wake up in the morning and go, what would be the least rewarding thing I could do today? Well, sometimes we do, but we do it anyway, because ultimately there's a larger reward. So if you get up and you don't really want to go to work, but you do it anyway, guess what? You're doing it because you're trying to achieve certain other goals. And one of the things in substance abuse treatment we talk about is helping people look past the immediate gratification and look more toward their long-term goals, good orderly direction. So, as I said earlier, we need to get your name. So if you would input your first and last name, that way we can make sure that you get adequate, accurate credit. That would be fabulous. I'll give you just a couple minutes, well, a couple seconds. It shouldn't take you that long to type your name. Okay. The next question, again, not a hard one. What's your email address? This enables us to email you your certificate and any information that we may need to in the future. Okay, I'm going to go on and go ahead, but you can go ahead and finish typing that in and just kind of listen as you're doing that. So, in preparation for this presentation, I want you to think of a client that you've had difficulty motivating. We all have them. And think of a client that you've been able to easily motivate. This is one of those clients that you think back and go, oh, that was a dream client. Okay, think about what are the differences in their personality, in their goals, in their diagnosis, in their socioeconomic status, in their educational level. Let's really just kind of start brainstorming what some of their similarities and differences are. Part of motivation is making sure that we're communicating to people in a way that meets their needs and helps them understand why we're asking them to do X, Y, or Z. So motivation is the key to change. You wake up in the morning, you're either motivated to get out of bed or you're not. And if you're not, you probably lay there and hit the snooze button 6, 7 times. And then eventually, at least for me, I get so tired of hearing the snooze button go off, that motivates me to get up and do something. But we're not talking about me. Motivation is multidimensional. That means, and we'll talk about this a little bit more on the next slide, but it's not just your thought process. It's how you feel. It's your social influences, peer pressure, if you will, or what you want to achieve or provide for other people. It's dynamic and fluctuating. Some mornings you'll be really motivated to go to work because you love the people you work with and it's a fun job and it's awesome. And other days you're going to wake up and go, you know, I'd really rather stay in bed today. So we need to pay attention to that and help patients, clients, understand that their motivation is also going to be fluctuating. Some days they're going to wake up or they're going to go through the day and they're not going to want to go to a meeting. And what do we say? The best times to go to a meeting are when you want to go to a meeting and when you don't want to go to a meeting. And when we talk about motivation, we're really talking about that word want. What do you want to do? Motivation is influenced by social interactions. We really enjoy being around positive people. We enjoy being around people who are like us, who get us, if you will. So if people are going to meetings and they really don't feel like they fit in, they might not be motivated to go as much, which is one of the reasons when I work with patients who are going to 12-step meetings, or any other kind of meeting for that matter, I ask them to make sure that they're finding a group that they feel comfortable in, because that's going to enhance their motivation. They're going to look forward to going to seeing those people. And we also talk about the social interactions in terms of what types or what degree of socialness, if you will. Some people, and I always throw my husband under the bus with this, he tends to be more of an introvert. He enjoys being around people, but a couple at a time. Me, on the other hand, I get jazzed if I think about going to do a presentation in front of 100 people. I love being around a lot of people because I draw energy from them. Same thing when we're talking about education, work, or meetings. You want to help that person understand what sort of social environment is comfortable for them. If they don't like being around 100 people at a time, sales might not be the best place for them. It may be if you want to do some one-on-one sales. But again, you need to look at the person's temperament and preferences and what's going to add stress and what's going to motivate them. Motivation can be modified. If somebody is not motivated to go to a meeting because they don't like being around 50 people in a room, okay, so let's look for a smaller meeting. Let's look for a home group. If they are not motivated to go because they need to get more sleep, so getting up at 7 o'clock in the morning to go to a meeting before work isn't going to work for them, all right, let's look for a noon meeting or an evening meeting. The same thing can be true, again, for just about everything. If we're talking about working out, if we're talking about job schedules, if we're talking about just about anything, ask the person, what are their preferences? I was just helping a organization work on some manuals and some revisions for JACO accreditation. And over and over and over again, and asked, what are the patient's strengths, needs, attitudes, preferences, and goals? That's what we need to look at, because it doesn't really matter a hill of beans what I want. It's what our patient wants, and the short and long-term goals, and how we can help them achieve those goals faster. Motivation is influenced by the clinician's style. To a certain extent, we are going to help propel people. And part of that style that can be helpful is working with the client and saying, okay, this is your goal. This is where you are right now. So let's together draw a little bit of a roadmap to figure out how you're going to get from point A to point B. Okay, so motivation is dynamic and fluctuating. This is your first question. True or false? If you would go either to your window or on your smartphone and select an answer. Okay, again, you'll be able to continue to do that, but I'm going to go ahead and move on. Help increase motivation by focusing on client strengths. If they come in and they tell you they want to be happier, okay, well, first we've got to say, what does that look like for you? But then we say, what is it that makes you happy? Instead of just shooting in the dark and trying to figure out what's going to work, let's focus on the client's strengths. What have they done in the past that's helped them feel happy? In the past, when they have been happy, what was different? What would they like to do now? What are their hopes? What are their dreams? Let's look at that and then start piecing it together and creating some sort of a plan with the client. Asking them the entire way, is this something that sounds like it would be helpful? Is this something you're going to do? Because a lot of clients will tell us yes just to pacify us. The counselor says we're supposed to do this, we're going to do it. And then they get home and they're like, yeah, right. That doesn't do us any good. And that's what I tell my patients. I say, you know, I have lots of ideas, but my ideas may not work for you. So I need you to be honest with me about what sounds like it might work and what sounds like a really crazy idea. And let's figure out what works for you. We need to affirm their abilities to succeed. It's hard when you're depressed and you can barely get out of bed to even envision waking up in a month and wanting to get up and do stuff. It's hard when you've been drinking for 20 years or even 20 months and you've lost just about everything to envision building all that back up again. So we need to start with small steps. Make sure we increase the number of successes our clients have, daily successes, and affirm their ability to succeed. Help them identify people in their social group or in their support group or wherever who they can look to and say, that person did this, I can do it too. We need to use empathy more than authority. There's a certain amount of being a cheering squad and saying, yeah, I know you can do it, let's go, you need to go do it. You really need to try it. That's authority. Empathy is going back and saying, I know you're exhausted and you can't even fathom doing this right now. So let's talk about what you can imagine doing. What part of this could you start with? Again, think back to that person who it took every ounce of energy they had to even get to your office that day. That's it for them for that day. That was a really huge step. So what can we ask them to do tomorrow? Maybe get up at a reasonable time, 8, 8:30, 9 o'clock, and get dressed, which may not be something that they're doing regularly right now. That's a step. If that's all they can do the first day, that's fine. Then you can talk about how did it feel to actually get out of your PJs. Recognize co-occurring disorders. That means, and I use that term very loosely. Co-occurring disorders, typically we're talking about mental health and substance abuse, but there's also physical health issues that may be going on, social issues. I mean, there's a reason back in the day of the DSM-4, because I know we've moved to 5 now, but there were multiple axes because we wanted to look at the interaction. Co-occurring disorders are things that are going wrong in that person's life. They're not necessarily disease states, but it can be addiction and depression. It can be thyroid problems. You know, if they have hypothyroid, they may feel depressed. Well, isn't that awesome? If we can get their thyroid stabilized, we may be able to help them have some energy so they can start making those steps. I very, very much encourage you to have your clients get a physical workup, you know, if they haven't had one within at least 6 months or a year. If their symptoms just recently started, like 2 months ago, and there's no notable reason for it, again, you might have them go to the doctor and just get a physical workup to make sure there's no physiological cause for what's going on. We want to use client-centered treatment, making sure that we're paying attention to our clients, here we go, strengths, needs, attitudes, preferences, and goals. Respect their autonomy. And one of the stories that I love to tell is when I was working in Florida, I had a patient come in. I was running an outpatient program at that point, and the client came in and she sat down, not, hi, how you doing, my name is. I am not going to 12-step meetings. I am not doing this. I am not doing that. I'm not doing the other thing. And I'm, okay. And my response was, all right. It doesn't do me any good to know what you're not going to do, though, so tell me what you're going to do instead. Because we have to put something down on this piece of paper. You're going to do something. And she just looked at me for a few minutes like, you're not going to argue with me. And so we started our dialogue at that point. She was waiting for me to tell her what to do and not respect her wishes or her wants or her belief system. And as soon as we took that off the table and we said, you're the director of your treatment. I'm here with you 3 hours a day. You're on your own 21 hours a day. So it's up to you to work with me to help me understand what you will do, and we can work together to help you achieve your goals. So, motivation is the key to behavior change. Is that true or false? Okay, so we're going to talk about the types of motivation here. Emotional motivation makes you feel better. Things that make you happy, things that relieve guilt, things that, make you want to do something. That's emotional. Cognitive motivation is that emphasis on it's the right thing to do. I may not want to do it, but I need to do it. A lot of us make New Year's resolutions to exercise or stop smoking or do something or other. And a lot of times there are resolutions to do things that we've been putting off because we weren't motivated. Why? Because we didn't want to do it. So we need to find that cognitive reason, why do we need to do it? And work on developing the emotional motivation of, okay, how can I make this at least tolerable, if not something enjoyable? Social motivation, peer pressure. Maybe if you want to start exercising more, you find a workout buddy. Or maybe you and your spouse go on a walk after dinner every night. And if you don't have a spouse or your spouse doesn't want to work out, maybe you get a dog. It doesn't have to be a human social pressure. I can tell you, my dog, when she decides she wants to go out, there is no stopping her and there is no tolerating her. So she motivates me to take her outside. So we've got to figure out what the motivation is for our patients to achieve their goal. I usually start out with the why question. Some people don't like that word. But I say, okay, you want this to happen. Tell me why. What's the purpose? What's the benefit? How will you feel when this is achieved? And in what ways will this impact the people around you? Positively, negatively? And who can you enlist for support? Who can be there who will be supportive and cheer you on? Those are all things that you want to start out with, and I encourage people to write them down. Why? Because when our motivation starts to wane or wax, I never have figured out which one comes in or out. That's like ebb and flow. But anyway, my blonde roots are showing. So what you want to do is have them write it down and have them keep it somewhere where they can review it every day. Oh yeah, this is why I'm doing this. I had one patient who was trying to quit smoking, and she was doing it partly because she wanted to be there for her kids because her father had died from lung cancer. So she kept a picture of her kids in her purse where she used to keep her cigarettes. And every time she would kind of reach in there out of habit, she'd get that picture and she'd be like, yeah, this is not what I want to be doing. I need to not smoke. So that's one thing that you can do. We're also going to talk in a little while about providing alternatives. Whatever somebody was doing was serving a purpose. Drinking serves to numb pain, help you forget. Ask the person, what benefit did it have for you? Helped you relax, helped you sleep. Well, that's not really true, but some people think alcohol helps you sleep. Smoking, people often say it helps calm them down. Depression. Now, what's the benefit of not getting out of bed? Well, when we're depressed, our body is saying, I'm out, I'm done, I can't deal with it anymore. I'm hopeless and hopeless, and I just don't have any more energy. Okay, so let's start there. That was your motivation. So in order to counteract that hopelessness and helplessness, we have to find something that's going to give you hope and empowerment. So you got out of bed today and you came here, so you clearly don't want to feel this way anymore. Let's talk about why that is. And start talking about those aspects of motivation. Approaches. The frames approach is your textbook approach that we're going to talk about in the next slide. The decisional balance exercises. Now, these are my favorite. You draw a 4-quadrant grid, and you look at the benefits of use, or whatever their behavior is, and the drawbacks to it. And the benefits of the new behavior, and guess what? The drawbacks to it. So one of the things that we're going to talk about is that there are benefits to use. It made the pain go away. There are benefits to depression. It's your body saying, I can't do it anymore. Why are you engaging in these behaviors? And what are the drawbacks? If they're in your office, they want to change for a reason, those are usually easy to come up with. The benefits to change, this new behavior, they've already probably thought of a lot of those. Great, wonderful, that's easy. The drawbacks to change, ooh, maybe you didn't think about that. Let's take exercise, for example. New Year's resolution. Benefits to not exercising, it's easier. It doesn't take a lot of time. You can sit on the couch, you can watch your favorite shows, the list can go on. The drawbacks to not exercising, you have less energy, put on weight easier, can't eat as much, clothes don't fit as well. Okay, so now let's look at the change. What are the benefits to exercise? Clothes fit better, have more energy, tend to be nicer to be around, because a lot of people, when they have more energy, tend to be more social. And the drawbacks to exercise, again, it's going to take some time. You're going to have to reprioritize some things. It's not always fun, but you can make it fun. It is, something else that you have to do. So you want to take all those things that might hinder motivation and say, okay, how can we get rid of this? Let's talk about the drawbacks to exercise. You don't have the time for it. Well, why don't you work it in with something else that you're already doing? Like if you've got a dog, take the dog on a run instead of just walking out into the backyard and watching Fido run around for 20 minutes. Make it fun. Sometimes when I don't want to work out, I'll go to the gym because, now that we have TVs there, and that's one of my many vices. I'll go and I'll watch TV while I walk on the treadmill. Am I running 6 miles? No. But am I getting some energy? Am I getting some exercise? Am I getting some of that stress out? Yeah. And I made it fun. I got to watch Primetime Lineup while I was working out. So you need to look at, okay, how can you make this worthwhile? How can you make this less painful, if you will? You want to look at the discrepancies between personal goals and current behavior. Make sure there's flexible pacing, because just as motivation waxes and wanes, your pace is going to need to wax and wane. When people are really motivated, they're going to charge. And when they start to lose that motivation or get tired or distracted, they're not going to move as fast. And I like to think of it as plateaus. When you're going up multiple flights of stairs, you go up about 12 stairs or 15 or whatever's in a flight, and then you have a landing. And then you go up some more, and then you have a landing. And that's how I like to help clients envision goals. You're going to go up those stairs, and you're going to go up it with some attitude. And then you're going to get to that landing, and you're going to say, oh, I'm out of breath. I need to regroup for a second and, see how far I've come. Don't look down, look, and then go up the next flight of stairs. We need to give them a chance to catch their breath because other things are going to come in and take priority. Your kids may get sick. Well, that's going to take priority over going to the gym, maybe. So these are the things that you need to make sure that they're aware of. They're not always going to wake up with that go-get-it attitude. So how are they going to deal with it? How are they going to be kind to themselves? And what sorts of parameters are they going to set for, can you take a day off? Can you take a week off? Can you walk instead of run? Obviously, we're still talking about exercise here. And help them understand that if they're going to do something for the rest of their life, they need to make it work into their life and not just be super rigid. And have personal contact with them. Make sure if they're coming in to see you, obviously you're having personal contact. If they miss a session, at least try to call and say, hey, I just wanted to check in. I know we missed our session today, and I wanted to make sure you were doing okay. A lot of times that little element of, I care about you, and yes, it's important, and oh, by the way, how are you doing on those goals? By nature, we generally want to please other people to a certain extent. So what we want to do is make sure that they know that we're there, and we're supportive, and we're encouraging. So, does a person stay motivated once they're motivated? Actually, now that I'm reading that question, I kind of gave you a made it a little difficulter. Ooh, good word. More difficult than it had to be. Because the question meant, once somebody's motivated, do they keep that same level of motivation? Okay, the frames approach. This is in tip 35. You can read all about it. We're going to go through it kind of quickly, but it is a really good place to start, especially for people who are in pre-contemplation. That means they haven't even realized they've got a problem yet. They're here because somebody told them they have to be. So we want to provide them feedback regarding their personal risk or impairment compared to the rest of the country. How excessive or normal is your drinking? If you're throwing back 24 beers in a weekend, how normal is that? Is everybody doing it? What are the risks? Drinking that heavily. Responsibility for change is placed squarely and explicitly on the client. We're catalysts for change, but we can't make people change, which goes back to that whole motivation thing. If they're not motivated to change, nothing's going to happen. We want to give them advice in a non-judgmental manner. You can do this, this, or this. Your goals are your goals. It's not for me to say whatever. The first job I had out of college, I worked for felony probation, and all of my patients were felony drug offenders and convicted. And they had to do 12 weeks with me, which they just loved. Anyway, so we would talk, and they would say, I use pot. I don't see what's so wrong with that. I drink, and obviously, for a lot of them, they minimized, rationalized, and justified their use. But instead of really hammering on that and just going off on my own agenda, I said, okay, that's not for me to say. Those are your goals about how you want to live your life. But I can tell you this. While you are on probation, this is going to cause you a problem, and it's going to have you go back to jail. So, if you use and you test dirty, you're going back to jail. Are you willing to maybe not use, at least for the period of time while you're being randomly drug tested? That's their choice. If they don't mind going back to jail, that's their choice. Most of the time they're like, no. Okay, so let's figure out how you can stay clean and sober while you're in the program. And then after you get out, you can reevaluate. Menus of self-directed change options and treatment alternatives are offered to the client. What are your options here? AA is not for everybody. Some people just, like that patient I told you about earlier, come in and say, I'm not doing it. Okay, what are you going to do instead? Have options for people. What is the purpose of AA? Community, support, understanding from people who have been there. Those are the big ones. So what can you do instead that will provide those same sort of things? Support, community, and understanding from people who have been there. Maybe it's your church. Maybe it's, let's talk about different things that may serve that same purpose. Empathic counseling. That's what we go to school for, so I don't need to explain that. And self-efficacy is engendered in the client to encourage change. Some people have been told all their life that they're screw-ups, and they're always going to be screw-ups. So you know what? It's scary to even think about succeeding. And nobody's ever told them they could succeed before. So not only are we telling them they can succeed, and we're helping them succeed, some patients view that as us also setting them up for a fall. Well, just like I talked about the flight of stairs earlier, sometimes we talk about rock climbing. And yes, when you're climbing up that wall, you've got to put in those pegs. But there's a reason you have all your gear on. And clearly I'm not a rock climber. But if you climb a rock wall without any gear on and you fall, you go all the way to the bottom. Our goal is to make sure to put in pegs frequently enough that if you fall, you just go back a little bit. Up 5 steps, back 1. So we want to make sure that that person has a safety net so they don't go all the way to the bottom again. Because then they're looking up the mountain going, do I really want to do that again? And we have to help them maintain that motivation. Help them understand they can do it. Help them identify times when they've done it in the past. Maybe they have 6 months of sobriety. Or they're depressed right now, but they have been happy before. Help them understand that. Decisional balance exercises we talked about earlier, but obviously, since it's one of my favorite, I put it in here again. Have them make that quadrant and really look at what are the benefits of your current situation. And why are you doing whatever it is, smoking, drinking, not exercising. Those are the big ones that I can come up with off the top of my head. We want to look at what purpose that serves, because it serves a purpose. And if we don't meet that same need, guess what? Chances of you relapsing are pretty high. Another example, if you go on a diet, if you will, and I won't get on my soapbox about diets versus nutritional changes, but you try to start eating healthier. So every time you crave chocolate, you eat celery. Is that solving or serving the same purpose? Yes and no. Is it giving you calories? Well, theoretically, yeah. Is it giving you something to chew on? Well, theoretically, yeah. Is it meeting that same need? No. So you want to say, why are you craving chocolate? For some people, they're craving chocolate because they need the sugar. For some people, they're craving chocolate because it's a comfort food. For some people, they're craving chocolate for some completely other reason that I can't think of right now. But if we don't meet that need, then they're going to eat that celery and they're still going to be craving chocolate. So let's figure out what the need is we're trying to fulfill. One of the things that I talk about with decisional balance exercises is in identifying needs. I know for myself, whenever I'm craving salad, I'm dehydrated. Because, I like salad, but I don't love salad. So if I really want iceberg lettuce, which is like 90% water, I probably can figure out that my body's trying to tell me I'm dehydrated. One of my patients took that and said, okay, that's interesting. And she did some research on the internet, and she found a whole chart that listed different foods that people crave and what mineral, vitamin, or substance they may be lacking, and their body's trying to tell them that they need it. So pay attention to what you're craving and try to figure out, have I been eating healthfully? Am I eating emotionally? Am I eating because I'm bored? Am I eating because I'm trying to stop smoking and I need to put something in my mouth? These are all reasons. We have to meet that same need. Okay. So the question is it is not important to understand the benefits of the undesired behavior. True or false? So if you're working with somebody who's an addict, it's not important to understand the benefits of using. Obviously, these are not as much opinion questions as they are questions about the prior slides. But create discrepancies between goals and current behavior. You want to be an awesome mom or dad. Great. So how is using, getting caught drunk on the job, losing your job, and getting arrested supporting that goal? You want to be there, like my client who was trying to quit smoking. You want to be there for your kids and to see your grandkids and maybe even your great-grandkids. Okay, so how is smoking getting you there? Now, some people may say, well, it's keeping me so I don't have a heart attack from stress. All right, so that's the benefit of that behavior, and we need to figure out something else we can help you do for stress and to help calm you down, as opposed to smoking. That way you're happy, healthy, sane, sober, and stable when you meet your great-grandkids. Help clients identify the discrepancies or gaps between their future goals. You may clarify this discrepancy by asking, how does drinking fit in with having a family and a stable job? The miracle question we all learned, or most of us learned, in counseling. You know, it's Counseling 101. If you woke up tomorrow and you weren't depressed anymore, what would be different? What would life be like? Well, okay, so we start there. And that gives us an idea of where the person wants to be in 10 years. But what about right now? So how do we get from where you are right now to over here? It all begins with the first step. So let's take a step. What can you do today to get you 1 inch closer to where you want to go? What can you do tomorrow? What might you be able to accomplish in the next 30 days? Set micro goals. Those are goals that they can accomplish on a daily basis. And maybe weekly goals. The furthest I would go out is a month, because once you start looking towards 6 months and a year, people get overwhelmed and they start living in the future. And one of the keys is living in the present. Whoops, sorry, went the wrong way. Flexible pacing and personal contact. Meet the client where they are. If they're not motivated, they're not going to really want to brainstorm ideas for achieving a goal. Ask them, okay, you're not motivated to do this, get clean and sober, for example, but you came here today, so you're motivated to do something. What is that? Stay out of jail, get your spouse off your back, keep your kids. What is it that got you here today? Let's start there, and let me see how I can help you continue to achieve that goal. And use as much time as necessary with the essential tasks of each stage of change. I always used to love it when I worked in residential and people would come in, they'd do a week of detox, and then they'd do 30 days of residential and proudly announce at the end of 30 days that they had worked the 12 steps. Okay. They probably, and in their mind, they probably had, you know, I'm not disputing that, but what they need to understand is they didn't spend enough time on each one. And if you've been doing something for 20 years, you're not going to completely fix it in 28 days. So you want to use as much time on these basic tasks as needed. If you need to spend 2 months on step 1, then by all means spend 2 months on step 1, because guess what? It's been my experience that honesty, step 1, and understanding powerlessness and what you can and cannot change tends to be one of the biggest hurdles for people in recovery, whether it be from depression, anxiety, anger, grief, addiction, all of the above. So spend as much time as you need to on that to get honest not only with other people, you're not lying to them anymore about stuff, but with yourself. Be honest with yourself about how you feel, what you want, what's going on. And have personal contact with the client. We talked about that earlier. Help the clients to get ready by negotiating a plan. You wouldn't get in your car in Orlando, Florida, and plan to drive to Baton Rouge, Louisiana, at least most people wouldn't, without having some sort of a plan of how you were going to get there. It's a long drive. You're going to drive straight through. You're going to stop to eat. Are you going to take interstates or back roads? We don't have the benefit of having a GPS for life. So you can't say, well, I'll just program my GPS and listen to what it tells me to do. Well, I guess you could call that your conscience, but I digress. Negotiate a plan. Write it down. What are you going to do? Where are we going? So part of the first thing is identifying, you're in Orlando. Are you going to Baton Rouge, or are you going to Lenexa, Kansas, or Nashville, Tennessee? Offer a menu of options. Well, you can fly. You can drive. You can take back roads. You can take highways. There are a lot of ways to get there. Some people prefer the scenic route. Some people prefer the fastest route. What do you want to do? Develop a behavior contract. And that sounds negative. I kind of think of it more of a treatment plan or a map, a road map. Back in the day, I'll age myself here, back when AAA gave out triptychs, and we didn't have computers and iPhones and stuff. Yeah, I'm that old. But they would tell you where all the rest stops were and everything else that you were going to need to know about. And you would chart out your route based on avoiding construction and whatever else. So here we're going to develop a behavior contract, and we're going to say, okay, you want to get from point A to point B. Let's figure out how to do it in a way that is not going to impede you by interfering with your life or other areas of your life that are important. Identify and lower barriers. Transportation, work. There's a variety of things. And in treatment, we also talk about the whole biopsychosocial. We need to make sure that the person is getting access to their medication. They're getting access to food. They've got a safe place to sleep. All of these are going to negatively impact treatment if they go wonky. Have them enlist social support. Again, you're with them 1 to 3 hours a day, maybe. So when they leave you, they've got a whole lot of hours that they've got to fill. And if they are by themselves and they feel like they're out there flapping in the wind, chances of success are lower than if they have social support, people to go have coffee with, people to go to meetings with, people to go hike in the forest, whatever they want to do. With permission, offer advice. Once you get to know your patient, periodically they'll say something and you'll go, really? Offer advice or observations. And I try to stay away from advice because, if somebody offers me advice, I rarely take it. Because I'm a bit of a control freak. But I offer observations. Point out the discrepancy between what somebody says now and maybe what they said last week. Make observations about their behavior or their presentation or what they're talking about. A lot of times we will see relapses coming long before the patient does. We'll notice changes in their behavior, changes in things that they do on a day-to-day basis or their presentation. And we can point those out and go, could be you just didn't sleep well last night. but you really look like you're struggling today. Is there anything to that? And they'll say yes or no. And even if you're right, they may still say no, but you've planted the seed, and they'll go home going, maybe Dr. Snipes was onto something. Assist the client to negotiate finances, child care, work, transportation, or other potential barriers. And have the client publicly announce plans. Now, this doesn't mean getting on the television and going, by the way, I'm an addict and I'm not going to use anymore. But it does mean finding their family. And I define that really loosely. Anybody who they can call at 2 in the morning when they're having a crisis, anyone who is a positive, sane, sober social support, great. Let's bring those people in and let's see how they can help you, how they can be your cheerleader. And have them understand the steps that you're taking so that they can make sure to help you along the way. When the client is ready to start changing, there's a difference. But, that's my least favorite word. But it is one of the most telling words because it negates everything that came before it. I really appreciate all the hard work you did last week, Sam, but I need you to do X, Y, and Z. I really hope that you can stay clean and sober, but that doesn't really matter because you've got to go to jail now. We want to look at the yes buts. If a client says, yes, I can do that, but, and starts giving you excuses for why they're not going to do it, you might as well just be banging your head into a wall because they're not going to do it and you're wasting your breath. So what you want to do is say, okay, what is it you're going to do? And you'll find that when you start from that perspective, you don't get nearly as many yes buts, if any. And it makes it a lot easier to interact with the client because it feels like you're closer to being on the same page. When the client no longer asks questions about the problem, but more about how to change. One of my patients that I was working with recently had done really well. He had gone all day without using, and then he went to bed, and he felt all of his thoughts started racing, and he felt like he was drowning. And, you know, we all get that way sometimes. Some people call it a panic attack. Some people call it anxiety. For him, he just said it felt like he was drowning. He couldn't breathe. And so then he got up and used. The good thing was he made it all day. So we talked about what he did all day and how that had changed when he laid down at night. Well, obviously, you're trying to quiet your mind at that point, and you can't distract yourself. But he said, how can I continue to stay sober? How can I deal with that? Because I know when I lay down that's going to happen. And I said, okay, let's start talking about options. And we brainstormed and came up with multiple options to help him so he could actually lay down and have some hope that he might be able to get to sleep. The client appears calm and peaceful. It's like, okay, I got this now. States openness to change. I have to do something. Okay, if a patient says that to me, I say, great. What do you think that would be? And if they say, I don't know, well, then you can go down that road. A lot of times patients have an idea in their mind about either what's going to work, what they need to do, or what they think they should do. And we need to look at whether their conceptions are what's going to work for them or it's going to set them up for failure. When they express optimism, great. And we really want to make sure that we highlight every success. If you've got a client who's trying to start working out and they went to the gym yesterday, awesome. Maybe they went to the gym and they didn't really even work out. They just sat in the sauna, but at least they got to the gym. Let's reward that. Instead of being critical and saying, well, why didn't you? Great. Maybe tomorrow you can try getting on the bike and pedaling with no resistance. I don't know. Talk with the client. And have the client experiment between sessions with new ideas and new things that they think may help them achieve their goals. Barriers. We're setting them up for failure if we don't talk about barriers. Just like you're setting yourself up for failure when you're going on that road trip, if you don't plan for traffic jams and detours and stuff, how are you going to handle that? Ask what has gone wrong in the past. When you relapsed before, how did that happen? Take me back, not just to when you relapsed, but maybe 6 months before that, and what was going on? What started to whittle away at your sobriety? Find out if they anticipate problems. I had one patient that I worked with who was an alcoholic. She was a polysubstance user, but she was an alcoholic, and her family owned and ran a bar. And she said, the expectation is that I'm going to come back and I'm going to bartend. And I said, okay, well, let's talk about that, because that's probably going to be a barrier, or at least a very strong challenge to your sobriety. Provide all necessary information about different ways you can avoid it, different ways you can deal with it. Sometimes you're not going to be able to avoid stuff. Billboards that advertise alcohol, not always going to be able to avoid them. So how can you deal with them? How can you stop those intrusive thoughts about, I would really love a drink right now? Sources of barriers may include family relationships. A lot of our clients come from families that are dysfunctional, whether they're depressed or they're addicts or they're grieving or whatever it is. There may be family relationship issues that are unsupportive of their recovery. So we need to talk about what those look like and how to deal with them. A lot of our clients really dread holidays because going to family reunions and spending an entire 2 or 3 days with family is like having dental work done with no anesthesia for a lot of our patients. So, okay, how are you going to deal with Uncle Tom when he gets drunk and belligerent? How are you going to deal with this, that, and the other? What do you expect, and how are you going to make it through? Let's create a plan. And what is your safety? When we worked in residential and patients had a certain amount of clean time under their belt, if they wanted to go home on a pass, whether it was for a holiday or something else, they would have to develop a relapse prevention plan. But then we would also have a safety plan. If you're trying all this and it's not working and you're on the verge of using, drinking, whatever, call us. And we had a safe word, and the counselor would go pick the client up. Health problems can be a barrier. Depression or other negative feelings that sap your energy, sap your motivation. And bureaucracy. For some of our patients who don't have food, access to medical care, or safe housing, guess what? They're not really concerned about working on their self-esteem or doing some of those other non-tangible things because their basic needs aren't getting met. So we need to make sure that we help them find opportunities to get their basic needs met. If you're not sleeping well, you're probably not going to be as motivated or as energetic or as anything, at least not me. I can tell you that for sure. I need sleep. If you're not getting good nutrition, your body may not be able to process whatever you're eating to make the neurotransmitters that you need in order to feel stable. You may have diabetes, and you may need to have certain things going on between insulin and good nutrition in order to stay healthy. So there are a lot of things that we need to look at besides just emotional health and maybe thought processes. help them brainstorm solutions to those barriers. Because generally there are solutions. It may not be something they want to do, but that's a whole nother motivational bridge to cross. Examine and interpret non-compliant behavior. Non-compliant means you're not listening to the patient. And sometimes it means the patient hasn't articulated everything. So there's a piece missing. If a client is using, despite all the evidence that he or she shouldn't be using, and the client saying, I don't want to use anymore, I don't want to go to jail, but then they continue to use, then you need to say, okay, you had this choice, and it was more rewarding to use, so what's going on with that? What need are we missing? It may be you're not connecting with the client well. It may be the client has withheld some information, sometimes unintentionally. So each time the client has a lapse or a relapse, it's important to look at why. Help me understand why this happened so we can fine-tune your relapse prevention plan. Okay, in summary, and there's one more question after this, so don't leave me yet. There are different goals and tools for each stage of change. So if somebody's pre-contemplative, that means they don't think they have a problem. You're going to want to figure out what it is that they're motivated to work on. Whereas if somebody is in the action phase and they come in and they go, you know what? I don't want to drink anymore. It's ruining my life. I need to stop. Help me. Well, that's a whole different ballgame. Use different interventions. You meet the client where they are. Understand that even one session can make a positive impact on the client. My goal is always at the end of the assessment session to reinforce the fact that the patient is making a positive step and try to figure out one or two things that they can do between that assessment session and the first treatment session in order to kickstart their process and get headed in the right direction. We need to remind clients that lasting change takes time and effort. You may have a couple steps back here and there. You may not be motivated every single day, and that's okay. None of us are. And it's important to examine any reasons that your motivation may be falling back and take positive steps in the right direction. And all clients have the ability to learn to make positive choices and changes. They all do. So we need to affirm to them that they are making positive choices and changes for them. Decisional balance exercises can be used to help people identify their motivations. Identify the reasons why and why not. Okay, thank you for joining us today, and have an excellent weekend. Bye-bye. Okay, there were a couple people who missed questions, so we're going to go back really quickly through the PowerPoint slides so you can answer any questions that you missed. The first one, obviously, is what is your name? Can't get credit if we don't have your name, so we want to make sure that everybody who participated gets credit. Okay, and now we want to know your email address. Okay? Motivation is dynamic and fluctuating. Is that true or is that false? Is our motivation always 100%? Motivation is the key to behavior change. Do we do things if we're not motivated? Once a person is motivated to do something, they stay motivated. It is not important to understand the benefits of the undesired behavior. So it's not important to understand the reason our clients use. All right, and the last question. Decisional balance exercises can be used to help people identify their motivations. Okay, fabulous. Well, thank you all for participating today. And again, have a wonderful weekend.